Hello, this is Annette Rebel from the University of Kentucky, and today's videocast will be about blood therapy procedures. Um, Not only what you need to know about blood component therapy, but also, most importantly, what we need to know about not using it, meaning minimizing the use of blood components. So learning objectives of this videocast are: think about what we can do for not utilizing blood component therapy in each time period of when we encounter a patient, preoperatively, intraoperatively, and postoperatively. When we cross the bridge, that we say, like, now we do need to use blood component therapy. What do we need to know about using them, the pro and cons, risk benefit decision-making process? And so not only the positive, but also the negative side effects and complications with blood component therapy. This videocast will follow this outline. We talk about blood conservation strategies and how we can optimize our oxygen carrying capacity without using autologous or allogeneic blood. Then we'll talk about what we need to know about where those blood products coming from we are going to use, how we prepare our patients and our products for compatibility, the effects of storing blood components, and then last not least, complication of blood product administration. So as I said earlier, the first thing I want to mention here is starting off, talk about blood component therapy, think about what we can do to not have to use it. So try to conserve our own blood as much as possible. So the blood conservation strategies, the majority of reasons to use transfusion can be attributed to three different areas: preoperatively existing anemia, then excessive intraoperative blood loss, and unfortunately also inappropriate use of blood component therapy. So therefore, blood conservation strategies focus on optimize hematopoiesis to address preoperatively existing anemia, minimize bleeding and blood loss, and also to optimize our physiological tolerance of anemia. I really like this graph out of a publication from Shander in 2012, which really illustrates the implementation of blood conservation strategies in all time periods of perioperative care. So in all stages of preoperative, intraoperative, and postoperative period, we should think about, like, first, what we can do to optimize hematopoiesis to either avoid or treat anemia. The second pillar, what can we do to minimize blood loss or bleeding? And then the third thing to think through is, like, if anemia has occurred, what can we do to optimize our physiological threshold, how to tolerate the lower than optimal oxygen carrying capacity? So some of those things we will go through in more detail, but it's a really nicely structured way how to think about the process. Preoperative anemia is a very important part for us to keep in mind, because the prevalence of patients presented for elective surgery is at least around 30%, probably higher depending on the patient population that you're treating. So in patients with malignancy after chemo, probably higher. Patient showing up for elective orthopedic surgery, hopefully a bit less. The most common reason is iron deficiency anemia, so female population menstruating or postmenopausal, surely at high risk for iron deficiency anemia. Anemia itself is an independent risk factor for increased morbidity, mortality, and length of stay after surgery. Also, the use of blood component therapy, specifically packed red blood cells, also has been found to be a risk factor for adverse outcome. But you don't know if the anemia leading to use of blood component therapy is actually the underlying cause for increased morbidity, mortality, and length of stay, or is it a use of the blood component therapy? So to summarize what we'll go through in the next slides, but the recommendation is identify the patients at risk with enough time to intervene. So measure the hemoglobin more than 4 weeks before surgery. So if you decide to do something about it because your patient is anemic, then you have to have enough time for therapy to actually restore a normal oxygen carrying capacity. Also, there's something about the preoperative autologous donation, when the patient has either already knows undergoing a high risk for blood loss procedure, or we know that the patient has a very atypical blood type. It's going to be difficult to find compatible blood. Those patients would benefit from preoperatively donating their own blood, having enough time to restore their own oxygen carrying capacity and hemoglobin levels, and then to receive this blood during the surgical procedure. But here are the problems with this procedure. First, the timing issues. How early enough do you going to let this patient donate to still have good blood available, but still allowing the patient to restore their own hemoglobin levels? Then, the administrative process in the blood bank with this donation is relatively significant. You have to make sure that the right patient receives his own blood. So there are storage concerns, administrative concerns, and then what you're going to do with the blood if you didn't use it. Coming down to who's going to pay for this. It's a costly procedure and only worthwhile when you really know the patient's going to benefit from it. So this algorithm, out of a very recent publication, actually makes it very clear the way how I think makes a lot of sense how to approach this problem. You first start out with the surgical risk. Patient is presented to you. Is this a surgery where I have a relative significant risk that this patient will receive blood component therapy or lose a lot of blood? If no, then just proceed to scheduling the surgery. However, if there is, the next step is think about what patient am I looking at? Is this a patient who is at risk for preoperative existing anemia? If yes, or you don't know, then you have to measure it. And if you find that the hemoglobin level is less than optimal, then next question is, are there reasons for it? Most likely iron deficiency, B12 or folate. And then prescribe your supplements, give time to work, and then proceed to surgery. If it's a non-elective surgery, you have to balance now how much time do I have to wait? Can I start those supplements, or how soon do I have to proceed with the surgery? So like malignancy, you may not have that much time before a cancer has already progressed further on. So that then shouldn't warrant a discussion with your surgical colleague. How much time do we have for optimization? Is it worth doing it? If it's elective, truly elective surgery, and you have identified a patient as anemic, classify your anemia, start treatment, and postpone your surgery until the anemia is resolved. As I said earlier, the most common cause for preoperative existing anemia is iron deficiency. So the most bang for your buck is supplement iron, and also think about jump-starting your erythropoesis if this is appropriate. So iron supplementation, it's a microcytic anemia. If a patient is at risk for it, surely you can measure it by ferritin or transferrin levels. But here there's a iron deficiency formula, pretty easy to obtain. which gives you an idea of like ballparking what's your replacement dose. And then the question is like PO replacement versus IV. Traditionally, we are more used to with the PO replacement strategy, but it becomes more and more popular is the IV supplementation route. So PO, keep in mind there's a low gastrointestinal absorption rate between 20 to 30%. So therefore, you have to give it at least 6 to 8 weeks before you address a significant iron deficiency using the PO supplementation route. There are significant dose-dependent gastrointestinal side effects, which leads to poor compliance by your patients. As higher you use your supplementation dose, as poor is the compliance. So that were the problems traditionally with the PO replacement. So as I said, the IV route has become more and more popular. We have different formula now available. Gluconate, succinate, and dextrane are the still most commonly used ones, but there are also other formulations. And the formulation really has a huge impact on what is the risk of anaphylaxis. So sucrose is the one I've used the most. Anaphylaxis actually is, well, the risk for anaphylaxis is actually like less than probably 1 to 250,000. Not negligible. I mean, it's something you have to consider when you use that route, but also it's not that common. But with an IV formula, one short-term infusion between 15 to 45 minutes duration, you can provide up to 1,000 milligrams of iron, which may lead to an increase in hematocrit within the next 5 days. So this is surely something to consider when you have significant pre-existing iron deficiency and you have enough time to optimize your oxygen carrying capacity. Recombinant erythropoietin also has been used and was pretty popular in the past for addressing pre-existing anemia. The most knowledge we have about using this is from end-stage renal disease related anemia, where those patients get pretty chronically erythropoietin, recombinant erythropoietin supplementation to address their chronic anemia. There were 3 trials addressing the use of erythropoietin in critical ill patients. EPO 1 and 2 was done before the TRIC trial, which has changed significantly our transfusion practices. So the most relevant, EPO 3, was done in 2003 to 2006. It investigated the use of high-dose recombinant erythropoietin on patients with critical illness anemia. And what they found was, although the hematocrit increases within 1 week, there was no change in blood component therapy, a very small decrease on morbidity and mortality, on mortality in those patients receiving erythropoietin. However, there was a significant increase in venothrombotic events. It includes DVT, PEs, strokes, myocardial infarction, and cardiac arrests. So this has caused a lot of hesitation now in providers to use recombinant erythropoietin ad lib because of the significant thrombotic events associated with that medication. Erythropoietin has been used in a lot of other areas because of a lot of anti-inflammatory and immune modulating properties. So we're not done with that path, but for right now, hesitation to use it for preoperative anemia. If it's a megaloblastic anemia, vitamin B12 and folic acid supplementation also may be helpful to optimize your oxygen carrying capacity up in front. So moving on for the preoperative existing anemia now to what can we do intraoperatively to minimize our blood loss. The obviously thing, optimizing our surgical technique or surgical blood loss, it's not in our control. Okay, so this is a communication between you and your surgeon, but there are things we can do to minimize blood loss by just optimizing our perfusion pressures. Avoid hypertension. keep your MAP around 60, still maintain in-organ perfusion, however you monitor that. In addition, keep in mind coagulation is a temperature-driven process, so avoid hypothermia, avoid coagulopathy at all. So that also would imply monitoring coagulation function intraoperatively, for example, using a thromboelastogram. Last but not least, I want to talk about the intraoperative cell salvaging, the Cellsaver. So this is a pretty old picture of a Cellsaver. The newer machines look a little bit more fancy, but the system still works the same. You are capturing the blood lost on the field, and then you process it, and then you clean it and get it ready for retransfusion. You have to think about the Cellsaver early because you only can capture the blood on the field. You cannot capture it from when it's on the ground. So if you think about, you have a procedure where there's a significant blood loss on the field and your patient would benefit from getting retransfused, so you can avoid autogenic blood transfusions, then you have to discuss this very early on with your surgical colleague to use Cellsaver. So going through the steps again, the blood is salvaged from the field. We're using there already an anticoagulation because your flush is heparinized, and then the captured irrigation is stored in a container. When I have captured enough fluid, depends on the size of your bell of your device, then it gets loaded into the system and the blood is washed through centrifugation. The red blood cells are captured, everything else is washed off, and after several washing steps, those red blood cells are ready for reintroducing or retransfusion into circulation. The captured or the retransfused blood has a hematocrit in the ballpark between 50 and 60%. All heparin is washed off, including also there's no cell debris or any other blood components present in that retransfused blood. So there are no coagulation factors, okay. There are no platelets. It just truly should be packed red blood cells. So here come the problems you should consider when using Cellsaver. So if the heparin concentration or capture or the anticoagulation was not appropriate, you may have thrombi in that captured, and it may not have been separated enough into your centrifugation process. So there's thrombus development, and if you don't use another filter step, they can be retransfused and cause some embolic events. So when I use Cellsaver, I always have an additional filter in the retransfusion limb going back to the patient. Insufficient washing. So if you don't wash enough, the heparin is still present and gets retransfused, causing coagulopathy in your patient. Also, if you don't wash enough, cell debris may still be present, causing DIC, acute lung injury, and acute renal injury. Surgeons are always worried about the contamination, so if they are in the abdomen, like bowel content, or if they're malignancy, there may be cancer cells present, or any other toxins when it's an inflammatory process due to the surgery. Also in orthopedic surgery, the cement, etc., etc. However, studies will have shown if you do use a 40 micron filter additionally in the retransfusion limb, you can actually filter all those contaminants out, and the blood is as clean as it would be non-Cellsaver blood. Embolism, if do not hook up the limb from the Cellsaver directly to the patient, because the suction can occur and then therefore cause air embolization. So there always should be a second bag within the Cellsaver return and then getting retransfused to the patient. Okay, so now let's move on. The bridge to cross is when to give blood and when not. Transfusion triggers, there will be a completely different podcast dedicated to that, because this podcast already is long enough I don't really want to get into another 20-minute discussion about transfusion triggers. So for moving on here, let's just assume that we have made the decision, my patient needs blood. Unfortunately, it doesn't come in a can like that. So where does this blood come from? Now we will talk about the collection process and then preparation of the blood products before they are ready for transfusion. So the steps from donation to transfusion, like first we have to have a willing donor who goes to the donation center and gives about 500, 600 cc's of their blood, and this is collected into a little bag containing anticoagulant, about 60 cc's of anticoagulation solution. Mostly used is EDTA as a calcium scavenger, therefore avoiding the coagulation process. And during the donation process, there's like a steering plate to make sure all this gets mixed appropriately. After collection, this fluid gets centrifuged and separated in several components. This is where we separate plasma and platelets off, and then also like then have the PRBC or the red blood cell rich component or parts. In this graph, it shows you what preservatives can be added. So if it's just citrate, phosphate, and dextrose, you have a 21-day shelf life. If you add adenine, you can increase it to 35 days. And then the additional additive solutions, the adazole, the ADS1, ADS3, and ADS5, which then can bump it up to a storage time of up to 45 days. So the final packed red blood cell product contains about like 300 mLs solution, and the target hematocrit is between 55 to 65%. Before this gets stored, though, there's an additional filtration process to filter off the white blood cells. The white blood cells are contaminants, and they are linked to significant transfusion reactions. So we have learned that we want to minimize this contamination as much as possible. So additional filtration process, and then reduces the white blood cell component to less than 5 millions. And then your packed red blood cell gets stored. The storage temperature is between 1 to 6 degrees Celsius for the majority of packed red blood cells. Some of them, though, get treated with antifreeze with glycerol and can therefore be frozen. So either the atypical blood types can be stored that way, or our crisis massive casualty storage. That's where we have a huge amount of packed red blood cells stored away for a long period of time, meaning years. So they are available if we need a massive amount. Okay, but obviously before we use that, we have to have some time to get rid of the antifreeze. The anticoagulant addition and additive solution storage steps are really pretty heavily regulated by the FDA, and an acceptable shelf life is determined for packed red blood cells. If post-transfusion survival, 24-hour survival, is more than 70%. Okay. So that's what you can expect from your packed red blood cells and survival time. So all blood donations get screened for infectious problems or carriers. So routinely screen is for Hep C, Hep B, HIV, syphilis, and West Nile. And some of them antibody only, some of them the RNA as well, just to detect earlier infections. This syphilis serology is still surprising, but still present. Also here probably could be exchanged to a more antibody type test. But just keep in mind, this is our routine screening for infectious loads in our blood donations. So now we're at the stage where we have donated blood and now we have our recipient. So what do we have to do to ensure compatibility? We need to know the ABO type. It takes about 15 minutes. We need to have the rhesus type. Rhesus actually, we think it's a yay or nay, but now there are actually more than 40 different antigens which determine the rhesus status. We think there are only about like 5 or so which are clinically significant, and the one which is most immunogenic is the anti-D, and that's actually what we're testing for. 85% of the population are antigen D positive, so therefore rhesus positive. And the screening for this also is pretty quick onset. So you have an ABO rhesus typing within 15 minutes from as soon as the blood bank receives the blood. And then there's the antibody screen, and then there's Crossmatch. So what's the antibody screen? To identify if our donated blood has atypical antibodies, there's a commercial kit where we can screen for approximately 450 different common atypical antibodies if they're present or not. And so that's, when you get the antibody screen back, like it's positive or negative. Okay. About those typical 450 different antibodies, which we screen for that. If a patient does not have a previous transfusion history, the yield the patient has atypical antibody is relatively low. However, if a patient has been exposed in the past to blood, foreign blood, then the risk increases. So the yearly alloimmunization rate is about 9%. And those atypical antibodies are considered clinically significant when they react at room temperature or with anti-human IgG. So the common ones we see is Cal, Duffy, those ones as are listed here in this little slide. That's the reason why it's important to ask a patient about transfusion history, as most times we don't know, but if they already can tell you, yeah, I've received blood in the past, you can already triage them in a higher risk category for that. So then there's Crossmatch, but here we really want to ensure that the direct contact of donor with recipient blood is compatible. The Crossmatch goes through an immediate phase, incubation phase, and anti-globin phase. You see the time frames here, so the whole process probably within 60 to 90 minutes. However, this is almost a historic slide because most blood banks now have transitioned to an electronic process where you know the composition of your donated blood and you know the composition of your recipient blood, so therefore you can perform this using a computer. Still, some time needed, so time frame without, like for crossing out, probably 45 to 60 minutes. However, if atypical antibodies are detected, what that means is now we have to identify which atypical antibody is it, and then find compatible blood. So depending on if it's one or several atypical antibodies, how complex the composition is, cross-matching blood for a recipient with atypical antibodies can take a significant amount of times, up to hours. Hence, you need to give your blood bank heads up if you are planning on using blood component therapy on that patient. So I like to summarize this and strategize kind of like the decision between when do I need a type and screen and when do I upgrade or need a type and cross. First, I ask myself, do I need blood products in this procedure? This is based on my starting hemoglobin level and my estimated blood loss. Okay. So if I'm 100% sure this patient will need blood component therapy, you have already answered your question. You will proceed to type and cross. If this is a pretty reasonable, meaning plus minus 70% that I will use blood products in this patient, and there's a potential that this may happen pretty fast, I'm going to lose a lot of blood. For example, encounter IVC, I'm doing an aortic surgery, or upper abdominal close to the celiac plexus. Also here, that may turn me towards proceeding to type and cross. However, if there's significant blood loss, but most likely gradual, or I have an estimated blood loss, around 500 cc's, or I'm like less than 50% sure I will need blood products, I order type and screen. And then I follow up. Is my antibody screen positive? Then for sure I'm going to ask to cross something out, because this adds significant time to the availability from when do I need blood and when I have it. Or when I reach a positive transfusion trigger, like I've gotten, here, all indications are that my oxygen delivery is not sufficient, then upgrade to type and cross. Okay, I hope this graph helps a little bit, but this is exactly how I think when I work up this problem. So let's move on to what effects does that storage time have on our blood component? So there are some changes in morphology just by being cold in a non-energy generating area. Keep in mind, like erythrocytes don't have mitochondria. So they have the ATP, what they have, and they cannot generate any further. So having them in up to 42 days in cold, yes, that's why we keep them cold, to minimize the metabolism, but as more and more as they are eating up the ATP, and then they go into any ADP, and then any kind of phosphorus-carrying substance, 2,3-DPG comes to mind, their cell membranes gets leakier and leakier and spikier. Okay? As you see here in those pictures, okay, from day 5 to day 42, there's a lot changes morphology in the echinocytes, okay, the spheroechinocytes, so irreversibly deformation, okay, which then also will tell the spleen that those red blood cells need to be taken up because they're deformed and therefore most likely not well functioning. So spleen takes it up, and also the loss of the epithelioid structure of the erythrocyte minimizes the endothelial contact they have, and therefore less availability to deliver oxygen in the microcirculation. In addition, I already said, anything of phosphorus looks attractive because that is energy. So in the storage time, any phosphorus containing structure will be metabolized for the baseline metabolism. So 2,3-DPG, which is a very important catalyzer for the oxygen carrying function of the hemoglobin molecule, will be depleted. We also have decreased intracellular level of calcium, your membranes are losing their phospholipids, there's protein and lipid peroxidation for energy generation. To document what I just said about the 2,3-DPG, on the graph you see on the side, over time after the transfusion, there is loss in 2,3-DPG, and as it gets retransfused, okay, it takes several hours before 2,3-DPG gets replenished in your red blood cells, and therefore before they can really functionally participate in the oxygen carrying capacity. To document what I just said, there's a pretty interesting study performed in 2004 and 2005 looking at that when you retransfuse old blood, you restore your hemoglobin level, your hematocrit, but it does not necessarily mean that those red blood cells immediately will participate in the oxygen transport. So it will take several hours based on the 2,3-DPG replenishment before the hemoglobin can actually efficiently be loaded with oxygen. To summarize the impact of the storage time on the blood product quality. Old versus fresh blood. The older blood does need more time to increase their 2,3-DPG levels so they can participate in oxygen transport. That may take several hours. The deformed packed red blood cell will be taken up by the reticular endothelial system, the spleen, earlier than the non-deformed cells. And talking about the reticular endothelial system and the immune system, by giving them those distracting factors, you force them to focus on that and not to do other things. The immune modulation. And it's a hot topic in oncological surgery, because if you give blood component therapy to a patient during a cancer surgery, we do know that their outcomes and their recurrence rates are higher, probably due to the fact that we distracted the immune system, not taking up cancer cells, but taking up deformed packed red blood cells. The literature overall is very controversial on if fresh blood is better than old blood, etc., etc. So therefore, this is still something to keep an eye on right now. There is no need to prioritize fresh blood over old blood. You just have to keep in mind when you use it, pay attention to your storage time, because it will tell you what your product, how soon your product will help you in improving oxygen carrying capacity. Okay, so last not least, and this also is a quick topic where what we need to consider for using blood component therapy, meaning complications, risk-benefit decisions. Let's talk about the risk of transfusion reaction. If I know ABO and rhesus status only, most likely a 99.8% compatibility. If I add an additional negative antibody screen on top of it, I increase that safety by a percentile. Okay, so that's pretty good. But adding now, after I know ABO, rhesus, and have a negative antibody screen, now doing a cross-match, there's really not a big jump off. Okay. However, it's never 100% safe. You're giving foreign protein, foreign blood to somebody else. So therefore, there always is a risk for not only a transfusion reaction, but also for protein-based incompatibility. It's important to know if a patient had blood component therapy exposure before or not. Because as you can see here, uncrossed, and I don't know, or a patient had transfusion history, this is a pretty significant risk I'm exposing my patient to. Versus if they hadn't, it's a little bit less. But the goal surely is to know your ABO and rhesus status at least, which is 10-15 minutes. In an emergency situation, using uncrossed blood, if we know ABO and rhesus compatible, great, that's the route we should go. If we don't, we use O as a universal donor and O positive for everybody except female in childbearing range or female child. Because here we do not know if they have antigen D, so we should keep it negative and not sensitize them by exposing them to that. As soon as you know, transition to your ABO rhesus compatible blood type, unless you've already given more than 10 to 12 O based units, because at that point you have to retest and recheck when the blood loss situation is controlled. Now let's move on to the big topic of transfusion reactions, and I have selected the ones which are of most relevance to our intraoperative use. So I group transfusion reactions in two different groups: immunological based versus the non-immunological mediated complication. As you see here with the bold parts, like the immunological based, are usually related to components, meaning red cell, white blood cell, platelet, protein, T cell, or the overall of what we already discussed, immune modulation. Versus the non-immunologically, it's more kind of like how much and how fast am I giving that? Okay. Rate related, think about MTP. Okay, all those electrolyte shifts, all the temperature shifts, all the shifts in acid base status. Okay. Versus volume related. Okay, if I only use one blood component, for example, packed red blood cells, but I'm bleeding whole blood, I'm diluting my coagulation factors. That's why MTP, FFP to packed red blood cells 1:1, and with platelets either 1:1:2 or 1:1. If a patient is not actively bleeding but needs blood components due to pre-existing anemia, but also has CHF, there's a lot of volume we give. Okay. 300 cc's of a hematocrit of 55, that will double, okay, to a hematocrit of 30, dilute down, recruit extracellular fluid. So here, patient got like a a volume bolus of 600 to 700 cc's only based on giving 1 unit of packed red blood cells. Even worse for FFPs. If I reverse coumadin-based coagulopathy using FFPs, which is 10 to 15 cc's per kilo, I give up a liter of FFP to reverse an INR on someone who may have been in CHF on atrial fibrillation. That's what I went coumadin. Okay. So all those things kind of like, you keep in mind when you think about transfusion complications in the non-immunological mediated complications. The infectious risk. I alluded, we screen all our blood products here in the industrial world for the most relevant infectious complications. So therefore, Hep C, Hep B, and HIV are a relatively low risk, but your patients will ask you about that. Hep B is still the most common one. Okay, HIV and Hep C actually really low rates, not 0, but 1 to 1.5 to 1.3 millions. It's like 1 to 1.5 to 1.13 millions. But these are the developed countries. All this shifts a lot if you go to low developed countries. Here, these are numbers from Africa, where obviously those infectious complications are a lot higher. Bacterial contaminations for packed red blood cells, very rare, but more commonly seen in platelets. Platelets don't get stored that cold. They get stored at 20 degrees Celsius, so therefore bacterial growth is a much higher concern for platelet transfusion. So septic complications you see much more commonly in platelets. Parasites, malaria, we don't screen here because the rate is so low in our population, but in African nations, every third blood component at this point you can assume is contaminated with malaria. Prions, the Creutzfeldt-Jakob disease, all this surely fears, but we really don't have much data to comment on risk and screening. Now let's move towards the common immunological risks. There's hemolytic transfusion reactions, acute versus delayed, and we'll talk about this a little bit later on. Febrile, non-hemolytic transactions, anaphylactic T-cell based reactions, and TRALI. We will talk more in detail about the hemolytic transfusion reactions, febrile hemolytic transfusion reactions, and TRALI later on. But let's first go through kind of like how much do we have to worry about this? Okay. So the data are relatively old, but still the best ones we have. You look at the little graph. TRALI is reported more and more. The red columns are from a different database. But on FDA, the blue column is like, TRALI has been a significant concern. Hemolytic transfusion reaction actually is on the decline. The transfusion associated sepsis, as like platelets first, rate is like pretty close around, less than 10%. The graft versus host reaction also here on the decline, probably due to that we minimize our white blood cell contamination. The leukofiltration falls in there. The transfusion-associated cardiac output overload also on the decline. We are just more conscientious in patient at risk. So ultimately, the relevant transfusion reactions, TRALI, hemolytic transfusion reaction, are the ones we need to focus on. So, the red cell-mediated complications, the acute hemolytic transfusion reaction, and then the delayed form. Every one of you guys who went through the blood bank rotation, I think, should be master at this, okay, because that was our simulation experience. It's still a significant cause of transfusion-related mortality, most likely caused by an ABO incompatibility or atypical antibodies, don't forget those. Clinical error, most common cause. So that's the reason why two people need to look at those units before you hang them. It's despite cross-matching, the risk has not been eliminated, but you think about like only 13 events a year in 2005, that actually is quite an accomplishment how we have minimized those occurrences. If it occurs, it can be fatal. And again, it's not only EBO, it's also the atypical antibodies. What happens? Well, the donor is the antigen, and the recipient has the antibodies. It's an immunological reaction. Okay. IgE causes the intravascular cell lysis. The IgM causes the extravascular cell lysis. But what it does, it activates your complement cascade. It releases histamine and serotonin. So you see a full-blown immunological reaction, vasodilation, hypotension, bronchospasm, cutaneous flushing. For me, this is kind of like an anaphylaxis where I know the antigen because I know the donor red blood cell was the antigen. Okay. So our patient looks like that: febrile, agitation if they're awake, pain if they're awake, shortness of breath. All of these things in anesthesia we most don't see, but the flushing, the hemodynamic responses, profound hypotension and shock, and then late we have our hemoglobinuria and DIC, and renal dysfunction. Okay, so what do? Immediately stop the antigen, stop the transfusion, and then the severity correlates with the amount you've given, so that's why like stop it. If in doubt, stop it. And then as soon as you have your patient hemodynamically stabilized, send that unit in the recipient's blood to the blood bank so we can start working on what's going on. It may be an acute hemolytic transfusion reaction, but it also may be an anaphylaxis to protein. Okay? This one you don't know. But you hydrate this patient, fluid resuscitation, you treat the hypertension. Epinephrine surely comes to mind when it comes to an immunological problem. You want to have the systolic blood pressure with a goal around 100, but it truly depends on your comorbidities and your patient. For minimizing the impact on renal functions, maintain renal blood flow. Dopamine is not renal protective, but it increases your renal blood flow. You give fluids, and you want to have a urine output of more than 1.5 ml per kilo per hour. If you need to, force diuresis with furosemide or mannitol. The alkalization of urine is really more like to minimize the crystallization of the hemoglobin fragments in your tubular system. The evidence for this is very soft. Okay, it's can benefit your renal dysfunction, but if you have an anemic patient who is right now in need for oxygen carrying capacity and is you don't have any blood products to give them because he had a transfusion reaction, you want to review that step lightly. And monitor your coagulation function, send a tag, and treat DIC if it occurs appropriately as early as possible. Now, what's a delayed hemolytic transfusion reaction? Here, the sensitization of the recipient to the donor kind of comes more delayed. The risk is about 1% per unit, and like every patient will make some alloantibodies, but not every patient will develop a delayed hemolytic transfusion reaction. It can show up until 30 days post-transfusion, and get consult. This patient has an unexplained icterus, okay, like jaundice. Okay, what's going on? So that's where you have your direct and your indirect hemoglobin. Indirect and direct bilirubin, and when it indicates that it's hemolysis, that's when you have to think about it. This may be a delayed hemolytic transfusion reaction. The symptoms are relatively mild. Okay, a little bit of fever, not feeling well, progressive anemia because those red blood cells are destroyed, bilirubin level come up, and they also still may have a little bit of hematuria. It's important to work that up because it has relevance for following transfusion, blood transfusion if needed. So as early as we can, we should identify what caused this transfusion reaction, most likely atypical antibodies. And it should, patient and chart should be updated. Now let's move on to the leukocyte-mediated complications. There's the febrile non-hemolytic transfusion reaction, and then TRALI. And I promise you we will be done soon. The febrile non-hemolytic transfusion reaction is the most common transfusion reaction we see. Occurs 1 to 200 units, and I'm sure as an intern when you took care of patients on surgical services. At some point you got called because somebody had a temperature increase and had to be assessed because is it a febrile non-hemolytic transfusion reaction or is it a hemolytic transfusion reaction? This needs to be a differential. Okay, as common as the febrile is, okay, you got to rule out the significant, the much more fatal ones, and that would be sepsis or that would be the acute hemolytic transfusion reaction. So definition is like 1 degree of Celsius temperature increase in association with a blood transfusion and no other identified cause. Actually, that was the reason why we started the leukocyte reduction, because we have now realized that those febrile responses are related to HLA, which is a white blood cell bound system. So this is the contaminant which causes this transfusion reaction. Okay, as I said, you have to examine your patient. Don't assume it's a febrile non-hemolytic transfusion reaction unless you have ruled out other causes, because the treatment is completely different. Okay, so how does the febrile non-hemolytic transfusion reaction look like? Typical onset 45 minutes after transfusion starts, lasts about 1-2 hours. Patient looks relatively okay. The reaction is relatively benign. Okay, you stop the transfusion, you rule out the other causes, but then you slowly restart it, slower rate, okay, in supportive care, meaning acetaminophen, sometimes mopyridine has helped. And since we're using leukocyte-reduced products, it's actually less severe and less common. Now let's talk about TRALI. Okay. TRALI now is the leading cause of transfusion-related mortality. Okay. It's probably also much more identified, okay, since we know more about it, but truly the rate is increasing. It can be a fatal complication. The true incidence is unknown because it's still a diagnosis of exclusion, more or less. And every blood product can cause transfusion-related acute lung injury. Platelets, packed red blood cells, FFPs, okay, all of them, any blood products can cause it. How it looks like, it's ARDS, okay, just within a time where a patient has received transfusion, 1 to 6 hours, not immediately. If a patient complains about short of breath directly as the transfusion is going in or started, that has other causes. Okay, it either could be an acute hemolytic transfusion reaction or it could be volume overload. Okay, it's a cardiac decompensation. So when I say about ARDS, okay, that means acute onset of respiratory distress, severe hypoxemia, okay, bilateral lung infiltrates, and it's a non-cardiogenic pulmonary edema. Okay, and the patient is not septic and aspirated or other reasons to explain an acute lung injury. What we think happens with TRALI is that it's also a white blood cell based transfusion complication. Okay, so those HLA antibodies of the plasma donor initiate an immune response. And since the venous blood, the first capillary system, venous blood sees is the lung, so that's why there's a pulmonary sequestration and capillary leak. That's why it's such a fulminant pulmonary response. Donors with a higher amount of white blood cell antibodies have a higher risk of being associated with TRALI occurrence. So that's why multifarious women at all are at higher risk for like female donated blood has a higher risk of causing TRALI. We don't think it really is more like an antibody-antigen response. Okay, it's probably more like a two-hit model, which means the lung was sensitized, the immune system has already been ramped up in the lung to be vulnerable for this event. But the true pathophysiology for TRALI is still in the making. So this is the publication also from more than 12 years ago in 2007, where we have identified that female donations have a higher risk of causing transfusion-related acute lung injury, and that triggered the whole workup for white blood cell contamination and white blood cell antibody being related with this disease. So summarizing for our decision-making process, okay, how frequent it is, okay, he clearly can see that the deaths due to TRALI are on the upswing. Okay. Still an old publication, but this trend has only continued. It's just the best publication, the best graph I can find. Okay. For the other transfusion-related complications, the sepsis and the acute hemolytic transfusion reaction, all of this is on the decline. So that's for you to keep in mind when you use blood component therapy. Keep that in mind. Okay. What do we do with TRALI? The good news is actually, if you get control over the ARDS and can support oxygenation and treat the hypoxemia, it goes away pretty benign in a 96-hour time frame. So this is in my ICU time actually when it resolved that quickly. I was like, was that TRALI? Because other causes for ARDS usually don't go away that fast. But it is fatal in a significant amount of cases, so it is the highest risk, highest mortality risk when thinking about blood component therapy. Supportive care, maintain oxygenation, treat hypoxemia. That's the treatment strategy with TRALI, and you can minimize the risk by using leukocyte-reduced product. Is there a difference in what donor cohort we are using? All this is a blood bank question, not necessarily a provider question. So thank you for hanging in there with me for almost an hour. Sorry for this long podcast, but it was a big topic. If there are any remaining questions, and I hope not, but please, I'm always available if you have any questions or comments. Thank you for your attention.